Kyphosis is a distortion of the neck and upper and middle back usually caused by poor posture known as upper crossed syndrome, which is characterized by a mild to moderate hump forming at the upper back and lower neck region, rounded shoulders, forward head posture, tight chest muscles in front, and weak, stretched middle back muscles.
In this region, we have the superficial fascia that's been sectioned actually. It's quite thick here, and this is the spot where we have what is commonly known as a Dowager's Hump. And there's a mild representation of the Dowager's Hump in this gentleman's structure. And that tissue itself is a very dense, fibrous tissue where the fat that intervenes amongst the fibers is more a dark brownish reddish color as opposed to a light yellow or a canary yellow color, and that represents a stored packet of energy which has its own psychodynamic qualities that can be discussed and explored. This isn't complete then, this dissection. There's still more to go to completely reveal deep fascia man beneath superficial fascia man. But I thought it would be important to share this middling step between the layers.
What we're going to do, I'm going to put my left hand on his forehead, and then I'm going to put my index finger and my thumb so that I can palpate the suboccipital muscles. And don't be real light. Go in and really feel the tension. Well, all we want to do, this is not a treatment technique, all we want to do is feel the tension in the suboccipital muscles. How tight are the suboccipital muscles? Because then we're going to get them seated and see if there's a difference. So try to get an idea of either if there's one side that's tighter than the other, feel if it gets better when he sits down. Okay, so he's standing, and I feel some tension in the right suboccipital muscles. Let's have you sit down. He's seated. It's better. It's a little bit better in the right. Can you feel it's a little bit looser in the tight right suboccipital area? Not a lot, but a little bit. Okay, what does that tell you? That tells you that when he's standing, it's part of the neck problem is coming from the pelvis. It's coming from below. Because when he's standing in a standing position, if the suboccipitals get worse, then the tonic neck reflexes may be part of the problem. Now in this test, this is a very simple test and a very important test. All we're going to do is ask them to raise their head off the table, and the first motion that we want to watch is what is the chin doing. If the chin is coming straight up in the air toward the ceiling in the first 1 inch, we want to know that. Or does the chin tuck toward the chest in the first 1 inch? Those are the two key things that we're looking for. So Luke, just raise your chin up. Okay, what did you see there? Luke raised his chin. The first movement was more toward the ceiling than it was toward his chest. This is the motion. If the longus colli and longus capitis, which are supposed to be the neck flexors, were hypertonic and tight and overpowering the extensors, this is the motion it would be. He would raise his head with that. It would be a ducking, and then the head would come up like that with the chin tucked, if they're in good shape. You'll very rarely find people that have those longus capitis coli that will do that. Now, there's the young people, very young people will usually have that motion. And this is what Luke was doing. It came up a little bit like that, and that's what most of your people will do. They'll come up like that and then down. You know what I mean? Okay, so notice that, because that tells you what? That your anterior scalenes and your sternocleidomastoid still need some more work. You know, these anterior muscles, we don't like to work on them because they're very, very tender, but they need a lot of work. You lean into it with both hands so that if you were to let go, you would fall forward. That gets you back far enough and that gets your body weight. Keep your lumbar lordosis. And then you ask, I'm going to ask Luke to gently lift his shoulder toward his ear to a count of 3 or 4 or 5. Gently, gently, 2, 3, 4, 5. And then when he relaxes, I sweep toward the spine, lateral to medial. And I'm going to come over and I'm going to try to pull some of this tissue back. The trapezius and everything is wanting to roll forward. I'm going to want to pull some of that back. I'm not going to put a lot of pressure on the first rib, but I am going to try to sweep all of the myofascial tissue layers back. So again, I'm going to ask Luke to gently lift his shoulder toward his ear, and I'm going to resist with both hands. And when he relaxes, I'm going to sweep back toward the spine, but don't jump up on the spinous processes. Okay, so you can just do some general loosening techniques in there, whatever you want to do, you know, some filler techniques, but always come back lateral to medial. The reason we're going lateral to medial is because in forward head posture, the longissimus has a tendency to go wide on you. And when it does, we need to move it back toward the midline in order to create extension, to allow this spine to come back and help get rid of people who have Dowager's humps, things like that. I'm going to ask Luke to just gently lift his head up and down while I go in the groove. Why am I doing that? Because I'm putting pressure on the transverse processes, and if there's a transverse process that is not closing, if there's a bump on this side, the joint's not closing on the opposite side because there's some restriction in the fourth layer muscles that are preventing it from closing. And so if I go down and hook the fascia and he goes up and down and I'm on the transverse processes, it'll help that joint slide back into place. If it doesn't, you refer them to your chiropractic buddies, because that's why you keep good referral bases, because some of these joints are fixated and they're not meant to be mobilized by using muscles only. They have fast set nipping, they have cartilage degradation, and they're not going to close using this technique, and that's fine. You just do what you can. It's nice to have a biomechanical language so that you can communicate with these people or possibly work in the offices with chiropractors or physical therapists, PT, physical therapy assistants, or osteopathic manipulative osteopaths. Now I'll go on the other side, and he's still raising his head, lowering it, and raising and lowering it. I'm dragging the groove with my forearm all the way. Also, I like to use the flying V. This is the one that I used in the first technique, in the first set of videos. It's a technique that I thought I invented, but somebody told me that they have a Chinese technique, Tuina technique like this. But anyway, what I do is I come in the groove, and I have my strong hand down, my dominant hand down, index finger on one side of the groove, middle finger on the other side of the groove, and then I cross over and do the same thing with these fingers. And so now I've got the flying V. And I'm lowering the table a little bit where I can get some pressure. And now he does the same thing. He raises and lowers. And if I find a spot that is hypertonic, very, very tight, then I hold and I wait for a release. And I go all the way down the thoracics, and then I come back up, start back up at the Dowager's Hump area. And this thing you might want to do with your thumbs. I like to get in here with my thumbs. Now raise and lower. This is excellent technique for helping Dowager's humps.